Uh, I would like to thank the organizing committee and our dear Professor Mohsen Ibrahim, Siliman Gharib, and Professor Mohammed Salim for the invitation of this annual meeting. We are pleased to attend this meeting annually and update our knowledge about the silent killer, hypertension. Now we have the decision of hypertension, special consideration in women. I have the pleasure to introduce Professor Dr. Ghada Sayed. She will talk about what's new in hypertension in pregnant women. جميلة الأول. Okay. أنت الأول. I'm sorry. I have the pleasure also to introduce Professor Gamela Nasr. She will talk about the hypertension in treatment of hypertension in pregnancy. What's new?
يعني بسم الله الرحمن الرحيم. الحقيقة أنا سعيدة جدا ومتشرفة أني بشارك في المؤتمر السادس والعشرين للجمعية المصرية لارتفاع ضغط الدم، وبشكر أخي العزيز الأستاذ الدكتور محمد سليم على الدعوة الكريمة. طبعا كل التحية لمعالي رئيس الجمعية الأستاذ الدكتور محسن إبراهيم. طبعا احنا هنتكلم على الهارت ديزيز الومن في الأول، بس definitely in heart disease kills one person for every 3-second interval nationwide. ولكن in women global cardiovascular burden of cardiovascular disease in women, in 35% of all deaths in women are caused by cardiovascular disease. We have 275 million women diagnosed with cardiovascular disease in the year 2019. We have 8.9 million women died from cardiovascular disease in the year 2019. And definitely, I have to say that the high blood pressure is the most important risk factor contributing to cardiovascular disease mortality in women. And so, as we can see, it's prevalent, number one killer in females. Each year, more women die from cardiovascular disease than from cancers combined. For every woman that dies from breast cancer, there are 6 die from heart disease. And younger women are twice as likely as to die of a heart attack than a younger man, and 2/3 of women have at least one cardiovascular risk factor. I do have the honor to introduce the presentation about hypertension in pregnancy. What is new? Definitely, pregnancy is a stress test for life. And hypertensive disorders in pregnancy represent a major cause of maternal, fetal, and non-neonatal morbidity and mortality worldwide. These medical disorders are estimated to occur in around 10 to 15% of pregnancies. What's in definition of a hypertension? Sustained blood pressure elevation of more than 140 per 90 millimeter mercury or greater 4 hours apart, or more than 160 over 110 millimeter mercury, confirmed within short time intervals, minutes. This is the definition in pregnant ladies. And in pregnancy, we have 4 categories, as we all know: the preeclampsia, the eclampsia, the chronic hypertension, any cause. The chronic hypertension will superimpose the preeclampsia, the gestational hypertension. What about chronic hypertension? Hypertension existing before pregnancy or develops during pregnancy before the 20th week and persists after 12 weeks postpartum. Incidence is 1 to 5%. It's more common in elderly, obese, and Black women. Either essential or secondary must be excluded. إذا كان الضغط grade 1 hypertension before pregnancy ممكن يبقى normalized due to hypotensive effect, and no need to be treated. But it may progress to preeclampsia, and in this situation we call it superimposed. لكن if uncontrolled, we can think of secondary cause if it is uncontrolled, if there is hypokalemia, if there is renal impairment, or if there is history of family renal disease. gestational. Is that hypertension occurring after 20 weeks? Absence of proteinuria. There's absence of systemic findings noted with preeclampsia. The full diagnosis after delivery may develop preeclampsia at any time. It is preeclampsia. We are all afraid of that situation. It's 5% of all pregnancies. It's 10% of the first pregnancies. 20% of chronic hypertension during pregnancy. This is the definition. That's the preeclampsia diagnostic criteria. As we all know, regarding the blood pressure, there's, as we can see, there is the proteinuria greater than or equal 300 milligram per 24-hour collection, or proteinuria creatinine ratio greater than or equal to 0.3. In absence, there is if in the or in the absence of proteinuria, we should have new onset hypertension with the new onset of any of the following. لو ما كانش معاها proteinuria يبقى يكون معاها any of the following: either thrombocytopenia, platelet count less than 100,000, renal insufficiency, impaired liver functions, pulmonary edema, or cerebral or visual symptoms. طبعا الHELP syndrome أو hemolysis elevated liver enzymes with low platelets, it's around 25% showing proteinuria. What can we say about prevention of this? We can give 100 aspirin, low dose aspirin, 81%, 1 milligram per day, start after 12 weeks and stop after delivery. Of course, as we can see, that is, but we should consider aspirin, low dose aspirin for prevention. What about complications? We have preeclampsia complications for maternal and fetal. As we all know, that there is gives preterm delivery, stillbirth, placental abruption, and many problems for the mother. HELP syndrome, a distinct clinical entity with hemolysis, elevated liver enzymes, low platelets, and it occurs around 4 to 12% of patients with severe preeclampsia, having microangiopathic hemolysis, thrombocytopenia, and hepatocellular function. What about eclampsia? It is just you can diagnose preeclampsia and you have presence of convulsions not explained by neurological disorder, having some element in grand mal Caesar activity, and occurs to 0.5 to 4% or patients with preeclampsia. Is measurement different in pregnancy? We have to consider that in patients, in pregnant ladies, she should be no smoking, she should be no walking, there is no caffeine for 30 minutes, should have a seated arm, resting at heart rate for 5 minutes, feet flat on the floor with the use of proper size for the cuff. In about 5% of women, an exaggerated gap exists between the fourth muffling and fifth disappearance of cough sounds, with the fifth sound approaching 0. And this we can find in 5% of baby. Do you think that we can consider using home or ambulatory? It's probably superior to the office measurement of blood pressure in predicting outcomes. And of course, it may diagnose white coat and musket hypertension as well. I have the diagnosis as one of the hypertensive states with pregnancy. No, now what? Everything always depends on the gestational age, and we have to remember that preeclampsia always gets worse until the placenta is delivered. The tempo may be different in every woman, but it will always get worse. The standard goes, what about a lady with pregnancy, and she's a pregnant lady having hypertension? The stated goals of treating hypertension is the same as among different guidelines, and prevention of maternal target organ damage, of course, and trying to offer fetal protection. What we can see, if I stated a case of hypertension with pregnancy, I have to do complete blood picture, platelets, serum creatinine, transaminases, lactate dehydrogenases, test for proteinuria, serum uric acid for suspected superimposed preeclampsia, and as well, I should have a comprehensive fetal evaluation, estimated fetal weight, amniotic fluid volume, antenatal testing, such as biophysical profile and non-stress tests. What's new? There is an anti-angiogenic factors like tyrosine kinase 1 and soluble androgen at the high uterine artery pulsatility index in the second trimester are likely tools for prediction of early onset preeclampsia. And this is actually one of the early tools that you can predict preeclampsia. They do not, however, accurately predict preeclampsia, and their use remains investigational. Again, why do we like to use aspirin? Because it's a relative deficiency of prostacyclin, and the excess thromboxane A2 adds to the pathogenesis. Studies have shown that aspirin at low doses causes the preferential inhibition of thromboxane A2 and reduces the incidence of pregnancy-related hypertension. And at any patients having women with high risk factors for more than one moderate risk factor should receive low-dose aspirin, 81 milligram for preeclampsia prophylaxis from 12 weeks of gestation up till delivery. What's also new? Drugs such as metformin, sildenafil, statin for preeclampsia prevention are not recommended outside clinical trials. Daily calcium supplementation is recommended in populations at high risk of gestational hypertension with low dietary calcium intake. However, what about salt restriction? No clear evidence exists to support the use of nutritional interventions such as vitamin B, C, E, fish oil, sodium restriction, or bed rest, and should not be recommended routinely. Curative. We all know that the patient who's pregnant and having hypertension, delivery of the fetus and the placenta is the only real treatment of preeclampsia. Other conditions are not always suitable for this. Treatment aims to prevent or minimize maternal and fetal complications. Most important, we have diagnosed the lady and we did the investigations for her, and most important questions to ask. Can patient remain pregnant, or does she need to be delivered? If she can stay pregnant, does she need to stay in hospital or can she go home? What will be the answer? The expectant management. If there is without severe features, patient can stay pregnant until 37 weeks according to the guidelines. Manage blood pressure, bilateral or nifedipine, start regular antenatal testing to assess the fetal well-being, get weekly blood work to see if the things are worsening. Patients can be managed as an outpatient if she lives close, has transportation, and do not need to keep measuring protein in urine once the patient has the diagnosis. We don't have to do this. We don't need to keep measuring protein in urine once patient has been diagnosed with preeclampsia, and because increased amounts of protein will not change the management plan or diagnosis. With severe features, I don't think we need to stay more. So with severe features, patient can stay pregnant until 34 weeks, may need to deliver before then. We are looking for 2 reasons to deliver her. And we need inpatient management. Antenatal steroids may be needed. ICU consultation, daily labs, antenatal testing, close monitoring of vitals. Actually, expectant management always depends on the lady's decision, the mom's decision to stay pregnant. This is what we call, now we know in the whole world we are having engaged patients, and really there is a very important concept in the field of cardiology precisely, that's the engagement of the patient. And we do have 4 stages for patient engagement. Maybe the top of that is shared decision making, and this is one of the situations you should look for the activated cardiac patient, where you should give the shared decision making to terminate the pregnancy. Of course, we all know that Caesar prophylaxis is the most benefit for patients with severe features, and start at initial presentation at severe range blood pressure. And we have, of course, the magnesium sulfate, very well known drug, as we all know. Medical therapy, A treatment of acute hypertension in pregnancy, a medical emergency requiring treatment to lower blood pressure within 30 minutes of confirmation to reduce the risk of maternal stroke. And we can give, of course, first line options. As we all know, the immediate resistance. We know all the oral drugs for severe hypertension, as we all know. Labetalol, methyl, dopa, and long-acting nifedipine, beta blockers. The second dose could be clonidine, hydrazine, and so, of course. What about, there's an interesting paper on the year 2022 about treatment of mild chronic hypertension during pregnancy. And actually, this is the CHAP trial. And it was to assess if treating mild chronic hypertension during pregnancy with a blood pressure goal of one more than for 140 of 90 would lower the incidence, less than 140 per 90. Would it lower the incidence of adverse maternal and perinatal outcomes? Than a strategy of withholding treatment until the blood pressure was 160 over 105 millimeter mercury. Actually, it had recruited around 2,400 patients, and half of them approximately have taken the active treatment, whereas the control did not have. And they included pregnant women with a known new diagnosis of chronic hypertension and the viable fetus before 23 weeks gestation. The primary outcome, as we can see, and this is the preeclampsia preterm, looking for small for gestational age, secondary outcome with composite maternal cardiovascular complications. And this is very evident data. As we can see, it is that the conclusion came up saying that in pregnant women with mild chronic hypertension, a strategy of targeting a blood pressure of less than 140 millimeter mercury was associated with better pregnancy outcomes than a strategy serving treatment only for severe hypertension and no increase in the risk for small for gestational age birth weight babies. Well, there is another concept, and I'm just trying just 1 minute or two, that the postpartum preeclampsia, this is it's onset around 4 days up to 6 weeks after delivery, and there is a loss of nocturnal dip, as we know. Non-steroidal and non-steroidal drugs may present with pulmonary edema. The pathophysiology, again, in this situation is not known. The treatment is just the same as prepartum with strict blood pressure control. And as we can see, there is risk factors. Definitely, there is vascular damage after hypertensive pregnancy disorders. And we have, all of them have, there is a part where you have an intervention opportunity, prognosis, and a meta-analysis that includes more than 3 million women, almost 200,000 women with preeclampsia, that the patient with preeclampsia had 2.7 times more likely to develop hypertension, and almost twice were more likely to have ischemic heart disease, stroke, DVT, but 11 times to have diabetes mellitus. And this is not very known why. Again, this is again the registry. This is still going in the Journal of American College of Cardiology. We do have new therapeutic approaches. Maybe there is potential new targets for the treatment of preeclampsia, sildenafil, endothelin 1 pathway, recombinant angiogenic factors, AT1 receptor agonist, autoantibodies, drugs with anti-inflammatory actions, maybe genetic approaches, and genetic approaches may have personalized medicine. This is the way you can in the coming future to look for the personalized medicine and genetic approaches. Statin, melatonin, also, these are all under investigation. So my take-home message is about use 140 over 90 as the target for threshold for starting medications. If the patient is still on medication at the start of pregnancy, keep them on this medication. If they are safe, of course, on pregnancy, of course, you should avoid using the ACE and ARBs drugs, initiate or adjust antihypertensive medication if blood pressure is more than 140 or 90 or greater, or at least 2 occasions, or at least 4 hours apart, titrate medications to titrate the blood pressure in a goal range of 120 to 140, 70 over 70 to 90. Labetalol and nifedipine are safe options, and definitely this is really very important. according to Ralph Waldo Emerson, this first wealth of health, and of course preventive medicine. And I like this equations very much, and I've said that we do have the equation proposed by the European Society of Cardiology, and as we can see, that's the blood pressure acquiring a central part in this very important equations. This is the 035150530. People who stay healthy tend to have certain characteristics. 0 stands for no tobacco. 3, walk 3 kilometers daily or 30 minutes in moderate activity. 5, take 5 portions of fruits and vegetables a day. Of course, blood pressure should be kept definitely 140, less than 40 as we can, and we should keep the lipid profile as optimal as usual, having total cholesterol less than 5 millimole per liter, LDL less than 3 millimole per liter. 0 stands for avoidance of overweight and diabetes. This is not cardiology. This is not just saying a very important Maslow's hierarchy of needs, as we all know that all of us have needs, but I think that this is a triangle of Maslow's, and this is the, as we can see, the ground basis of that's about biological needs. But at the top of the triangle is self-actualization, personal growth, and fulfillment. And I do think that the doctors, thank you very much.
Thank you very much, Dr. Gamela, for this very updated and illustrative talk. Do we have any questions?
Thank you very much, Professor Gamela. Professor Gamela, I'd like to ask you some questions, but I don't have experience about the preeclampsia and eclampsia. But I have heard since a long time about the dark or dark room without light. And what is the cutoff level if you terminate pregnancy or to continue on pregnancy of according to the blood pressure? Is it, suppose that it's 150 over 90, you can go to continue on and complete pregnancy? What is the level that you decide to terminate the pregnancy? And about the labetalol is an alpha and beta blocker at the same time, and we have injection of labetalol. What is the more potent, labetalol or alpha methyl dopa? What's in your opinion? Thank you.
You don't terminate a pregnancy according to blood pressure numbers only. You do have a lot of data. As we said, that if there is market, the general condition is very serious, you can have to terminate pregnancy before 34 weeks. But if the patient can withstand withstand the situation, you can up to 37 weeks. This is. So cannot just not a matter of numbers. You have to judge the patients. As we can see, that's the whole lot of medicine is going through the personalized type of medicine, and you have to tailor every patient according to each case. But about the oral drugs, as we know that labetalol is there, the methyl dopa, the long-acting nifedipine as well is there. There is metoprolol you can use in pregnancy, pindolol, propranolol, but it's better not to use atenolol as it's stated. You can use the second line oral drugs like clonidine, hydrazine, thiazide and loop diuretics as well. And of course, you should avoid some medications like the ACE and ARBs because they are causing, as we all know, phytotoxicity and renal system impairment. So you have a quite ample amount of drugs it's present in the market, and probably methyl dopa, as we all know, it is what is really we in real ground basis we use but you can use long acting oral nifedipine is there. You can use some beta blockers, and it may have a safe profile to give it in patients with pregnant ladies with hypertension.
Thank you very much, Dr. Gamela.
سؤال.
اتفضل.
احب اقول بعض الاخطاء الشائعه في حالات البريكلامسيا بيعملوا elective cesarean section خاصه في المستشفيات الخاصه والعيادات. احب اقول vaginal delivery is better than cesarean section.
Definitely.
وبريكلامسيا is not an indication for cesarean section.
يس، هو الحقيقه كان في يعني مقاله كامله up to date على العلاج البريجننت ليدز، وفعلا هو its vaginal delivery is there، وكلها بتقول ان انت you personalize according to the situation. ودكتور النساء الجينيكولوجيست هي طبعا مالتي ديسيبلينري تيم ابروتش، وطبعا دكتور النساء في الاخر هو بيختار المود اوف ديليفري، وديفينتلي اتس بيتر تو يوز فاجينال ديليفري. طبعا احنا عندنا مشكله في مصر خطيره جدا، اني بتناقش بقوه الفتره دي في المجلس القومي للمراه كمان، اني بقى في مال براكتس باليوز اوف سيزيريان سيكشن. دي مشكله كبيره جدا في مصر، ان احنا دلوقتي ان بقى اغلب الحالات بتستخدم وهي not indicated. فاي ثينك لا، هو it is the vaginal delivery it's the best way لو العيانه can withstand، او ده according طبعا للديسيجن of the gynecologist. I agree with you totally.
Thank you very much, Dr. Gamela. I just have one question. Do we have any statistical data about the incidence of hypertension in pregnancy in
10 to
Egypt?
15%.
Egypt.
It is there. It's a big number. It is not a very small number, but it's around 10 to 15%, which is really alarming. And I think we do have to look for. But what I'm saying now we are talking about the primordial prevention. طبعا يعني الفكره ان بتقولي primary وسكندري وتيرشري وكواترينري prevention، لا دلوقتي في البريمورديال. فالبريمورديال prevention ده هيفرق معنا كتير، انك انت تقدر الجينيتيك والابيجينيتيك والسكريننج للناس دي ممكن تو ديتكت كمان عن طريق فاكتورز كتيره، انك تقدر ان this lady will be prone انها هيجي لها هايبرتنشن او بري اكلامسيا. وطبعا في مكان للارتفيشال انتليجنس في الموضوع. الحقيقه احنا برضو ما رضيناش نجيبه، لان انت ارتفيشال انتليجنس بباك داتا عندك الرقمنه والاستخدام الداتا الكتيره جدا، تقدري تعرفي النهارده على فكره بالاي سي جي عن طريق الارتفيشال انتليجنس ممكن تجيبي الفانكشن اوف ذا هارت. ما كانش حد يتخيل كده، يعني انت we don't know why ازاي ده بيتم. فده I think ان هو the area is there ان احنا يتعمل داتا. we need فعلا شغل قوي في الفترة الجاية على الارتفيشال انتليجنس، ودي ممكن تدينا عندنا huge amount of data. مشكلتنا بس ان عندنا لازم يبقى عندنا بيئة تحتية قوية تكنولوجية، وفي نفس الوقت لازم يبقى عندك التعامل مع الداتا الكتير. لكن definitely احنا الفترة الجاية will witness total change في البراكتس في الطب in general عن طريق الارتفيشال انتليجنس، ومن ضمنها البريجنسي او hypertension with pregnancy.
Thank you, Professor Gamela, for this elegant discussion and elegant lecture. We are going to move to the next speaker, Professor Ghada Sayed.